that's going to take a lot. I mean, as far as you got to have the right equipment, you've got to have the right training, and your facility has to have or at least the place that you're in at this point, we're in the ER. The ER have to be equipped so that they can deal with it would have to be able to scavenge that gas, some kind of scavenging system into the wall or something. But Heliox first, and if Heliox doesn't work, then if you had everything set up appropriately, you had the means to do it, then you can consider like an inhaled anesthetic like halothane or isoflurane or one of those gases. Okay, so always think worker breathing can be better. You can better the worker breathing by making the gas mixture lighter, because being that helium is so lightweight, like very low density and viscous, it just makes it that much easier to breathe. Okay, so here are the final results that we ended up with here. So still, the majority felt that it was time for BiPAP. But again, we just probably didn't have enough information. We didn't really have enough information to know if he's experiencing ventilatory failure or impending ventilatory failure. Okay. Now, just as a quick trivia, now of course, there's bronchodilators that are made to be given IV and not just to be nebulized or given as an MDI. But did you know that albuterol can also be prepared as a syrup? So sometimes it could be prescribed as just like when you take cough syrup, you have like albuterol syrup, and it'll pretty much be the same dosages. It'll probably end up being like 2.5 milligrams or something of that nature. Now, so let's just start with a little bit of the history. They used to call X-rays Roentgenograms, and it was named after the founder here. This physicist was doing some experiments back in the day with electrons. He wanted to see how fast electrons could travel through a tube. And so what he did was he took like a glass tube, and more or less it would probably look like almost like a light bulb, like when you've got the little filament inside of the light bulb. But he had like two, if you want to say filaments, or two ends that were inserted into this glass tube, and then he pulled out as much of the air as he could, because he felt that without air in the tube, the electrons could travel even faster from one end to the other end. And so what he did was, when he turned on the power, he realized that he had this thing covered. First of all, it was inside of a big black box or something. So then when he turned it on, a screen that was on the other side of the room started to glow. And that screen apparently was fluorescent. And we know how fluorescent things work. As soon as something that's glow in the dark, as soon as it's exposed to light, it absorbs that light. Then you turn off the lights and then it starts to glow. So he was curious, like, why is the screen lighting up, or why is it like illuminating like this? And then he started to kind of like put some things in between his little glass tube experiment and that screen, like big boxes and everything else, to try to maybe block, because he felt like maybe it's something that's coming from this tube. And then even with the boxes and everything else that he was using to block, the screen would still light up when he turned on the power. So then he put his hand in front of it, and then he realized, like, whoa, he got like a shadow of his bones on that screen, on that fluorescent screen. So then this is the big discovery. Like, wow, we've got something that we could probably use for medical purposes. And then from there, there was no turning back. We've always been using X-rays in some form or shape to help with any kind of like medical procedures and diagnoses and things like that. And then this picture here is his wife's hand. So as you can see, she's got her wedding ring on her proximal phalange, and then this is like in a museum, I think, somewhere, just to kind of give credit to like this guy who really changed the world, I guess you could say, with this accidental invention that he ended up with. So you're not going to really probably find many people referring to an X-ray as a Roentgenogram anymore, but if they do, it's just because they're giving credit to the inventor, which is this guy, Willem Roentgen. Now, as far as like the basic principles, and this is essentially what you've got. You've got what's called a cathode and an anode that's inside of a tube. They call it the X-ray tube here. And all you're really doing is you're turning on power. You're giving some electrical current to the cathode. So this would be kind of like the light bulb situation where you turn on the light bulb and then it glows. The filament starts to glow. And all you're really doing is you're heating up the electrons, or you're heating up the atoms on that cathode. And because they're getting excited, they're releasing electrons. And as they're releasing these electrons, which are considered to be photons, because X-rays and light are pretty much the same. They're all electromagnetic energy. We just can't see the X-rays because they're not in our visible spectrum. But once the electrons or the photons are released from the cathode, this anode, this is a positively charged anode. It's usually like some kind of material like tungsten. And what will happen is the attraction will be so strong of these electrons or photons to this positively charged anode that they will hit the surface of this anode and pretty much scatter. It'll cause some of the electrons to just scatter. And some of them won't scatter, but still, whatever's being released, the scattering of these electrons, that is the X-ray. That's the whole point, is to try to get these really, really highly charged particles and then project them through the body, and then see what develops on the film, or see what happens on the film. And that's pretty much that. And it's very quick. If you watch, say, someone take an X-ray at the bedside, they're doing a portable X-ray. Once they get everything set up and they get everything positioned correctly, and then they of course get everybody to stand clear for safety, and then they hit the button or hit the switch, and it's like maybe a second. It only takes about a second, really, for all this to happen, and then to get the X-rays to literally travel through the body, and then you got your image. Now that link there is just a very, very like basic, like if you wanted to know how X-rays work. And really, X-rays are just pictures. I mean, just like when they used to take pictures with the old school cameras, the 35 millimeter film that had to be inserted inside of the camera, and never pull the film out of the camera after you've taken pictures, because otherwise the light would destroy them and would overexpose them and cause everything to turn black. So because X-rays are just like light, they're all considered electromagnetic wave, electromagnetic energy forms. As soon as the X-rays hit the film, they cause the film to turn darker. So as we know, anything that's going to absorb those X-rays is not going to have a chance to really hit the film. And then if it doesn't hit the film, it ends up showing up as white. So that's why we know with bones and very dense things, it's going to show up white. And then other structures like your muscles, tissues, etc., they are really not going to be able to absorb a lot of those x-rays at all. And that would mean that they'll show up a little bit less white. You'll see a little bit of like dark and a little bit of white. And then if you got something that really isn't going to absorb any light, like say air and like in the lungs, all those rays are just going to pass through and then hit the film and turn it black. Now, usually they will instruct the patient, take a deep breath and hold it, and then they'll shoot the film. But then that's not always the case. Like in this situation, if you're trying to rule out some type of foreign body obstruction, that maybe the child, accidentally put something in their mouth and now they ended up aspirating into the lungs, then they may, instead of telling them to take a deep breath, because as we'll see, they're probably already going to be experiencing a lot of air trapping as is, if there's something that's lodged in the upper airway. So what they'll probably do with that case is just get them to just force everything out, like blow everything out that you can, and then they'll take the picture. And then as far as what would you prefer? Would you prefer your patient come to the radiology department and stand in front of the imaging, the film cassette or whatever you want to call it, and then you shoot the x-ray from behind, which would be, of course, stationary? Or would you have your x-ray technician take a machine to the bedside and do it that way? So as we know, if you've got someone who's in, say, really bad shape and can't even like ambulate, or they're, say, like ICU, and they're, of course, definitely probably not going to be able to ambulate and go down to the x-ray department, then they're going to have to bring that machine to the bedside. And we know that that's just going to be, you're going to have a trade-off. It's convenient, you can bring the x-ray to the bedside, but as far as what you're going to see on your images, like things are not going to be in the right proportion, or they're going to be scaled a little bit differently. So today we have come a long way. We don't really have x-ray films that we can hold in our hand anymore like they used to. Like they used to have like a library in the hospital where you can go to the radiology library. And then if you wanted to see the film on your patient, you'd ask for it. And then they could give you the film that you can take and you can hold it. You can hold it up to the light to kind of like really see clearly and, do all those things that, you would have to do to try to get the best view that you can. And that's pretty much that. You got the film and it's been already exposed, or it's been processed, however you want to say it, and that's it. You can't make any adjustments after that. You just have to, again, do your best. Almost like those hologram cards where if you hold one of those cards in one angle, then it looks like something, and then you slightly turn it in another angle, and then it looks like something different. Those films, you kind of have to do that with them as well sometimes. You place them on the viewer, like the little box that lights up, you place it there, but then you still may have to take it out and kind of like move it around to really get a better view. So again, we've come so far, everything is pretty much digital now, where you can go in and you can adjust things like the lighting, make it lighter, darker, change the contrast, and make it a little bit sharper, and all of this other stuff. So like any like photo editing software type of abilities, then these x-rays are going to have the same type of system in place, more or less. And it's called a PACS system. PACS just stands for, you see, Picture Archiving and Communication System. Every hospital that's doing electronic charting is definitely going to be linked with the PACS system. And what that looks like is, no matter where you are, as long as you have access to the hospital's like server, and they call it like the PACS server, that's where all of this information is being stored on that central server. And that means that no matter where you are in the hospital, you log into your computer, and and then you click on x-rays or whatever, radiology, and then you start drilling down looking for your patient and to see what recent x-rays have been done or what recent radiology services have been performed. Then you'll be linking with this server and then looking at whatever they've already uploaded. So that helps a lot. You don't have to go anywhere in particular. You can be anywhere in the hospital, or you can log in from the outside of the hospital. Say like you have a physician who's working completely in a completely different city, and as long as they can log into that server, then they can access and upload and do what they need to do. So very, very, very convenient to have a PACS system. And this is a huge thing. So you have people like in radiology, or you have radiologists who would focus more on just the PACS system workflow part of this. And, and then they'll be constantly trying to find ways to improve and streamline. So now when we look at what's going on with a general x-ray, so this is like an example where you've got someone who is possibly unable to ambulate and go to the radiology department to stand in front of the film. But before we get into this image over on the side, these films can be, of course, however they need to have you positioned so they can get the best shot or the best imaging, whether you're standing up in front of the source or, again, you're lying down because you can't get out of bed, your side, lateral, etc. And then when we talk about the path, as far as the X-ray beam is going from where to where, posterior to anterior, from the back to the front, or from the anterior to the posterior. And so like with this example here, here's the X-ray source. So it's having to go from the anterior surface to the posterior surface. And then there's our little film or carriage or cartridge, I should say, that has the medium inside of it, the film or whatever it is that's going to capture the image. And this term right here, collimated is just meaning that after the x-rays are being released from that from the x-ray tube, they are really not focused. They're trying to go in every single direction they possibly can go. So you need some type of filtering system like lenses and mirrors and whatever else to get those x-rays to kind of focus and just be more like in a concentrated beam instead of like just scattered all over the place. So I guess you can think of, if you're like a Marvel Comics fan, Cyclops, his visor, the optic beams that he's shooting out his visor, they're collimated, because if he doesn't have the visor on, he can't focus, and if he opens his eyes, then his beams just go all over the place. So it's the same with x-rays. They have to be focused and collimated, so that way we don't run the risk of exposing the patient to all this x-ray. I mean, we just want to focus on just this area right here, not his head, not his legs, and etc. So our PA, this is a definitely preferred way of doing it, where you've got your x-ray being projected from the back to the front. And this is kind of a standard. They'll have you stand in front of, course, the film, and the x-ray source itself will be about 72 inches from you. And they usually don't have to adjust this at all, because this usually works out fine for most patients. I mean, I can't say for certainty that they don't have to maybe adjust this distance, but this is kind of like the standard. I've always seen this in anything that's related to like x-rays and as far as like PA film versus AP film, this 72 seems to come up a lot. And then with the AP film, you do the best you can. I mean, as far as you'll see the person who's doing the who's taking the X-ray, they're going to be adjusting the distance. They're going to be taking the device and moving it closer, moving it back, a little bit to the side, and they're trying to get the best angle and the distance, so that way the film will show up a little bit more clearer. And there are some things that are still, of course, going to be not in proportion, because your film is right there behind the back, and you're shooting from the front to the back. So as we know, the heart will always end up looking way larger than it really is. So ERs are usually going to have their own X-ray right above the table. So that means that a lot of times they'll have a cartridge. They'll just insert a cartridge under the table. There's like a little compartment where it'll fit. And then the X-ray machine, or the X-ray source, is just above the bed. And then they'll just have to, of course, adjust again the distance and that sort of thing. So they're not necessarily having to bring an X-ray. They're not having to push a mobile X-ray machine to the ER usually, because the ER rooms, like especially the trauma bay rooms, are going to have their own built-in X-ray equipment. So here we are. Heart looks a little bit bigger than it should be because of our technique. And we had to do an AP versus a PA projection. So we go into it knowing that you look at the film, and they'll have to tell you on the film, if they don't inscribe on the film in some way that it's an AP, we're going to assume that's a PA. And then I'll show you what that is all about and where it would usually show up on the film to let you know. Lateral decubitus, this is one of those positions where you are essentially having them lay on their side. So that way, if there is some fluid out there, it will move when you lay on your side. It's just like a bottle of water. If the bottle of water isn't full, if it's say like maybe half full, you lay the bottle on its side, and then the water starts to layer on the bottom because of gravity. So it's the same thing with this technique. You feel that there's pleural effusion, and it shows up as white in the basilar segment, then that could be atelectasis, because white is white. You can't tell one white from the other white just by looking at the X-ray, like when you're looking at a standard upright X-ray. So if it layers, then it's got to be fluid. If it doesn't layer, then that has to be consolidation, atelectasis. And also with an pneumothorax, they could do a lateral decubitus as well to see what's going on. But 9 times out of 10, if the MBRC is giving you something related to lateral decubitus X-ray, then they want you to immediately start thinking about pleural effusion, because you're trying to rule out a pleural effusion. Or if they're asking you for a recommendation after you've established that the patient is experiencing a pleural effusion, if they're asking you for X-ray recommendation, then they want you to think lateral decubitus to help officially rule out other things. Okay, and oblique is one of those techniques where we're going to just focus on the chest, because they do oblique projections for other body parts as well. But for our purposes, we're looking at someone who may have some rib fractures. And because of our ribs being of course, they wrap around from the posterior to the anterior, an X-ray is just a 2-dimensional picture, and you can't really see exactly what's going on the side. If you angle your patient a little bit like this, like 35, 45-degree angle, and this CR just stands for central ray. They're just saying that central ray, which is the X-ray itself, after it's being collimated. It's going, instead of going straight on into the body, it's going at this angle. So maybe we're thinking that the left side, maybe there's some rib fractures on the very left. And then what'll happen is it'll show up clearer because you may not be able to see those fractures on a standard AP or PA film. So the benefit of rotating slightly, or at least about a 45-degree angle, is you get a better field of view of what's going on with the ribs. All right, so now we have to start with the normal. So we look at an X-ray, and what is it that we're supposed to see on this film? So as I said before, it comes down to what ends up absorbing the X-rays and they don't really hit the film versus what doesn't absorb any of the X-rays and it completely passes through the body and it ends up hitting the film and turning it black. The more radiopaque or more dense, so I don't know if this works for you, but for me, opaque rhymes with cake. I used to think of like white cake, even though I know there's other kinds of cake and other colors of cake. But just when I was learning this for the first time, radiopaque cake rhymed, and it helped me to always keep them straight. So the more dense or more opaque that the film ends up looking, or the particular area starts to look, then that means that, again, you've got something that's absorbing those X-rays. And bones are usually going to absorb a lot because the bones, the atoms that make up the bone, like think about calcium atoms, they're huge compared to, say, like the atoms that are going to be found in the tissues, like just your soft tissue or your muscle. Those are smaller atoms, and they can't really absorb that energy. And these X-rays are like super duper energized. They're super highly energized. And so your bones are going to have a much better chance of absorbing that energy. And again, and they never end up hitting the film at all. And then, of course, with the air, anything that's hyperlucent, the word they use here is hyperlucency or hyperlucent. So when we think about like any kind of air trapping situation, pneumothorax or whatever the case is, instead of just being radiolucent, which is just the normal black that you should see, this is like the hyperlucency, where it's just like midnight black. Everything is just like super, super dark. Now, this could not be, we can't always assume that if you see hyperlucency, then that there's a pneumothorax or there's a problem. We have to look at the overall quality of the film, and that takes practice. It takes a lot of practice, and we're not learning radiology, but we have to use these films as part of our evaluation in our assessment. So they want you to be able to recognize when things are just not quite right, as far as this picture looks like it was overexposed, or this picture looks like it was underexposed. And this is the technician's issue. They do the best they can with their settings, and they're trained to they have to be able to recognize when to make certain adjustments to the machine based on like a patient who's maybe bigger or not as big, more muscular, less muscular, et cetera. And even in the disease process, they have to set things a little bit differently if they know this is someone with a lung disease versus someone who doesn't have a lung disease. But sometimes they won't get it right. And then the picture ends up coming out not good quality. All right, so let's take our 10-minute break, and then we'll proceed from here afterward.